So let's start part 2 of discussing the case-based question of most frequently asked upper limb questions, and these are Pondicherry University questions and high yield questions. I request all students to watch this and it will be very useful for you. A 35-year-old woman came to surgical OP with complaints of painless lump on upper quadrant of right breast. Examination revealed enlarged axillary lymph node on right side and loss of mobility of affected breast. What is the probable diagnosis? If you have watched part 1 and you can write this as breast cancer, because I have already explained what and all will be present, what and all clue will be given, so you can write it as breast cancer. And it is very important to mention which side. Okay, this is right side, they have given its right side. Then name the muscles related to base of breast. This question also we have already seen in part 1 video. Extent and parts of breast. Extent is also already taught. So parts and structure, when they ask only structure of breast, you can write everything under this. You can write nipple, areola, parenchyma, stroma, everything under structure of breast. But when they have differentiated as parts and structure of breast, in parts is that when you see, you should be able to say like that it should be. So this is breast, you will have areola here, you will have nipple here, and you will have axillary tail of spine. Breast is located in superficial fascia of pectoral region, but this is axillary tail of spines that will pierce the deep fascia, okay, through an aperture called foramen longus. So parts of breast, if they ask, you will write about nipple, areola, axillary tail of spines. When it comes to structure, you will write parenchyma and stroma. So when they ask only structure, write everything under this topic. Arterial venous drainage is already taught. So let's talk. So nipple is located in the fourth intercostal space, okay, and it is richly innervated by sensory nerve fibers, so it is more sensitive to tactile stimulation. Okay, it is more sensitive to sexual stimulation and becomes erect during sexual arousal. It also contains smooth muscle fibers that only helps it to erect or flatten. Okay, areola. It is located at the base of nipple. It is a dark pigmented area. This is called areola. And if you have seen part 1, you have already know it contains subareolar plexus of Sapi for lymphatic drainage. It contains, so this contains sebaceous glands, okay, sebaceous glands that provides oily secretion. So it gives lubrication and prevents from drying and cracking. And one important thing that you must write is, see, during pregnancy it will become enlarged. Okay, here it will become enlarged and enlarged during pregnancy, and it will appear as small nodular elevation which is getting enlarged, sebaceous gland, and this is called Montgomery's tubercle. It is very very important, please do write this. And let's talk about stroma. Stroma is the connective tissue and fat. It forms the supporting framework of the breast. Fat forms the most of the bulk of breast. Okay, connective tissue condenses to form the suspensory ligament. So this is suspensory ligament of Cooper. Okay, this is suspensory ligament of Cooper. It connects from fascia to dermis of skin or to the lactiferous ducts. Okay, you have to write this. Okay, this is the one. See, it maintains the protuberance of the breast. Protuberance. Okay. See, in old age, this becomes sagging. It is not like this very stiff, so that your breast becomes pendulent. Okay, pendulent breast or sagging breast is due to this suspensory ligament of Cooper. Now we'll see about parenchyma. Parenchyma is glandular tissue of breast that secretes milk. So if you see, we'll go for vary from micro. Normally we know breast contains lobules. In lobules, in lobes you have 15 to 20 lobes. Okay, in lobes you can further see lobules, and these lobules further contain acini. Okay, so from least if we go, see, you have acini, it forms lobules. Lobules forms 15 to 20 lobes. From there you have lactiferous duct coming. Okay, before it is draining into nipple, you will have this bottom enlarged. This is known as sinus. It serves as the reservoir of milk during lactation. See, this is acini. See, it is one lobe. It contains lobules, and you have one lobe coming. This is lactiferous duct, and this is sinus, and it is draining into nipple. So we have completed the sixth question. Let's go for next one. Arterial venous drainage is already taught. A patient presented with loss of contour of his left shoulder. On examination, he was unable to abduct his left shoulder. X-ray revealed the head of humerus to be inferior to glenoid cavity. What is the clinical condition? See, it is inferior to glenoid cavity. You can say this is inferior dislocation. Which nerve can be compressed? Name the muscle separate. This question is already told. Surgical neck of humerus is wound by axillary nerve. See, they have given contour. The same question with altered words. Loss of contour they have given. Inferior dislocation of which side? Okay, you should mention the side. Okay, this is left shoulder. Which nerve is compressed? Axillary nerve is compressed. And what are the muscles? I have already taught you. See, he is not able to abduct. So it is deltoid. One muscle is deltoid and another is teres minor. Okay, mention the structures responsible for maintaining the stability of joint. See, this also we have already taught, but not like this. Okay, see, you have shoulder joint here. So shoulder joint, you have rotator cuff muscles. Okay, rotator cuff muscles are sits. You have remembered by the mnemonic sits. Supraspinatus, infraspinatus, teres minor and subscapularis. These go and hold the head of humerus tightly and pull it medially and hold it against the shallow glenoid cavity. So it helps in maintaining the stability of the joint. Okay, you should remember that rotator cuff is very, very important. Okay, then you have the coracoacromial arch. So it prevents the superior dislocation. You have the coracoacromial arch preventing the superior dislocation, and you have long head of biceps brachii coming here, and it is bridged by transverse humeral ligament. This long head of biceps brachii prevents its upward displacement, and you also have, I said no, this is glenoid cavity, that is this is humerus. Okay, here you will have the glenoid cavity. This is glenoid cavity. This is deepened by fibrocartilaginous rim, glenoid radium. So four things: rotator cuff muscle. Second is coracoacromial arch. Third is long head of biceps brachii. Fourth is glenoid cavity deepened by glenoid labrum. The shallow cavity is deepened by it. So stability of joint we have learned. And next is muscles and movements. It is also already taught. So I expect that you have already watched part 1, so I am skipping this part. Okay, and 8th question. This is also a breast related question. A 60-year-old patient with carcinoma breast underwent mastectomy and resection of axillary lymph nodes. She complained of pain in medial aspect of arm. Which is the nerve is likely to get damaged during axillary lymph node resection? Why? What are different groups of axillary lymph nodes? Why do they need to be surgically removed in patients with breast cancer? First, let's see about B and then we'll go for A. Okay, see, different groups of lymph nodes you already know. The different groups of lymph nodes that are axillary group of lymph nodes, internal mammary group of lymph nodes, posterior intercostal you have, and then you will have posterior intercostal, deltopectoral, supraclavicular. In that, if you see, they have asked about axillary group alone they have asked. So in axillary group you have anterior. Okay, see this anterior, you will have axillary vein here, and you will have the lateral thoracic vein going and draining into this. So this anterior group lies along. So whenever you write about, only the question is about axillary group of lymph nodes, write which group in axillary, which group does it belong to, and where it is distributed, where it is located, its location you should write, and from where, which area it drains the lymph. Okay, put a tabular column like this, like which group, location, where it is located, along which muscle or which vein or which nerve, and which area it drains. Okay, write like that. So this is located along the lateral thoracic vein, and it drains upper half of trunk and major part of breast, upper half of trunk and major part of breast. Okay, the posterior one I said already. So you will have subscapular vein here. So it is called subscapular lymph node. So it lies along the subscapular vein, and what it drains? It drains the upper half of trunk posteriorly. Anterior is upper half of trunk anteriorly. This is upper half of trunk posteriorly, and axillary tail of Spence is drained by it. This axillary tail of Spence is in close relation. It is coming in contact with anterior group, but it is drained by posterior group. Then lateral. See, you will have axillary vein like this. No, the lateral group is lying along the axillary vein, and what it drains? It is located in the upper limb. So it drains the upper limb. Then you will have the central and apical group. Okay, central group is located in axilla. Okay, and it receives lymph from all other lymph nodes, and this lymph is going and draining into apical group. Okay, one important thing. So in this central, you will have the answer for first question. If you see, this central group is in close relation with intercostobrachial nerve. This intercostobrachial nerve passes along this central group. Intercostobrachial nerve passes along this nodes. So whenever this node is enlarged, this nerve is likely to get compressed, or else when you are doing surgical resection of axillary lymph node, this nerve can get damaged. So this intercostobrachial nerve is the lateral cutaneous branch of T2 spinal nerve. Lateral cutaneous branch of T2 spinal nerve that supplies the inner border of arm. Okay, so in the question they have mentioned that the person has pain along the inner border of arm. That is because this nerve has been severed. That's why this nerve have been compressed or severed. Something has happened to that, the nerve has damaged, and that's why the patient has pain along the inner border of arm. Area of distribution of this arm, you will have pain. Okay, so we have discussed apical, is not discussed yet. As apical, it is located in upper part of axilla, like apex of axilla. It what and all it drains. Okay, it receives lymph node from central group, and it also drains the deeper aspect of breast. Okay, we have completed this, and they have asked why you should resect axillary lymph nodes. You should resect axillary lymph node also because it is the way of spread of breast cancer. Along the lymphatic drainage only it is spreading, so you have to remove that. That's why they are removing. So radical mastectomy. So when they say mastectomy, they will remove, see, you have lumpectomy and mastectomy. Lumpectomy is only removal of lump. Mastectomy is that they are removing the whole breast with the axillary lymph nodes. Also, they also remove two muscles. They mostly remove P major and P minor muscle. Please do remember. And if they ask what is the most common site of cancer, that is axillary tail of Spence or upper outer quadrant. Okay, please do remember. With that we have completed. Sometimes they just don't give you a case scenario like that. They will have pain. See, they have given medial aspect of arm. If they have not given, they have just asked what are the nerves that will be damaged. You have 3 nerves that will be damaged, but here according to the symptom, intercostal is damaged, intercostobrachial nerve is damaged. You can also get long thoracic nerve damaged and thoracodorsal nerve. Thoracodorsal nerve is the nerve that is supplying latissimus dorsi. Long thoracic nerve is the nerve that supplies serratus anterior. Now let's go for the next question. What is carpal tunnel and what is carpal tunnel syndrome, and add a note on cutaneous innervation of arm. So you know carpal bones, there are 8 carpal bones. You will remember with the mnemonic, she looks too pretty, try to catch her. So this is scaphoid, lunate, triquetral, pisiform, and trapezium, trapezoid, capitate, hamid. So the 2 lateral ones and the 2 medial ones you have here. 2 medial ones and 2 lateral ones. This is medial, this is lateral, okay? This is medial, this is lateral, and the band that is stretching across here is called flexor retinaculum. So you have this carpal bone and you have this band, flexor retinaculum. So what is carpal tunnel? The anterior concavity of carpal tunnel is bridged by anterior concavity of carpal bone is bridged by flexor retinaculum, which is called carpal tunnel. We have completed the first question. What is carpal tunnel syndrome? For that you have to know what are present inside the carpal tunnel. Okay, first, flexor retinaculum has a superficial slip that is called ulnar carpal ligament. In that you will have ulnar nerve and ulnar artery will be present, and you also have a deep slip. Deep slip is for flexor carpi radialis. Okay, if you see here, this is the superficial slip, this is the deep slip. In deep slip you have FCR, and here you have the ulnar nerve and ulnar artery. What is the content of carpal tunnel? You have to know. Content is median nerve you have, and you have FDS and FDP. FDS is flexor digitorum superficialis and FDP is flexor digitorum profundus, and you have flexor pollicis longus. So when carpal tunnel syndrome is this get compressed, when this median nerve gets compressed, it is called carpal tunnel syndrome. So median nerve is getting compressed. So what are all the symptoms associated with it? If we see median nerve, what the median nerve supplies, okay? median nerve does not give any branches in arm. Okay, no branches in arm. If we see in forearm, it divides into two, anterior interosseous, one is main median nerve. So the anterior interosseous nerve supplies all the muscles in deeper aspect of flexor compartment. That is, it supplies flexor digitorum profundus lateral half, pronator quadratus and flexor pollicis longus it supplies, and in superficial compartment of flexor compartment, superficial part of flexor compartment it supplies. So that is, it supplies, see, flexor digitorum superficialis, palmaris longus and flexor carpi radialis. This is the superficial part of flexor compartment that it supplies. And then in wrist it divides into two parts. It divides into two branches, and medial and lateral, and it supplies two lumbricals and muscles of thenar eminence. Okay, muscles of thumb. Okay, thenar eminence. Okay, you have four muscles there. Adductor pollicis alone is supplied by ulnar nerve. All other three muscles, flexor pollicis brevis, abductor pollicis brevis, and one more, that is opponens pollicis. All these are supplied by median nerve. So when carpal tunnel means it is happening at the level of wrist, it is happening. So in hand and all, innervation is present. Only like hand is in the sense forearm, or in forearm innervation is present. It is only cut off at the level of wrist. So supply to hand is cut off. So first thing is wasting of thenar eminence. Like you cannot do the opposition movement is not present, because opposition movement is not present, and there is no abduction or flexion, because flexor pollicis longus and flexor pollicis brevis both are supplied by median nerve. So you cannot do flexion, you cannot do abduction, and you cannot do opposition, but adduction is spared. Adduction is spared because it is supplied by ulnar nerve, and there is no pointing index finger. Okay, if you see, it supplies the lumbricals. Okay, if you see for lumbricals, it supplies the first two lumbricals. You have four lumbricals and it supplies the first two lumbricals. See, lumbricals action is salute action. Okay, salute action. You will keep your hand like this. Okay, so this is metacarpophalangeal joint. Metacarpophalangeal joint is at flexion. This is metacarpophalangeal joint is at flexion, and interphalangeal joint is at extension. Okay, but this action will be reversed. If this action is reversed, it will be something like there is extension at metacarpophalangeal joint and flexion at interphalangeal joint. So here, since FDS is spared, FDS is spared here because the injury takes place at the level of wrist. FDS is spared. Pointing index finger will not be present. Pointing index finger, no pointing index finger. Okay, no pointing index finger. Sensor V innervation will be lost. It supplies the palmar aspect, lateral 3.5 aspect. Sensory innervation is lost because it is given by what? It is given by median nerve. So what are all four highlight things you will write is wasting of hypothenar eminence, and the subsequently with the muscles you have to write about. Sorry, it is wasting of thenar eminence, and subsequently you have to write about the muscles and the actions that is lost, and then you will write about the sensory loss of palmar aspect, lateral 3.5, and then you will write about the lumbricals. First two lumbricals is affected. Okay, first and second lumbrical is affected, so salute action will be lost, and here there is no, when you close the fist, there is no prominent pointing index finger because FDS is spared. Okay, because FDS is spared. That's all. Then what they have asked, so they have asked about, and add a note on cutaneous innervation. You should also write about the causes of carpal tunnel syndrome. Because of what carpal tunnel syndrome happens? Okay, carpal tunnel syndrome happens because of tenosynovitis, mixed edema, retention of fluid in pregnancy, fracture dislocation of lunate bone, and osteoarthritis of wrist. These are all causes that you should remember. And these are the features that I have explained. And you have this thumb is flattened, no? This is called ape thumb deformity. And you have the test that you do is Tinel sign and Fallon's test. Okay. Tinel sign is that percussion over flexor retinaculum reproduces patient symptoms. And also Fallon's test is that flexion of both wrists against each other for 1 minute produce patient symptoms. These tests are positive for median nerve injury. They have asked about the cutaneous innervation. This is palmar aspect and this is dorsal aspect. Lateral 3.5 is supplied by median nerve, and medial 1.5 is supplied by ulnar nerve. In dorsal aspect, same. In dorsal aspect, the medial 1.5 is supplied by ulnar nerve, and lateral 3.5 is supplied by radial nerve, except nail beds. Here the nail beds are supplied by median nerve. You should remember that. Now let's go for the last question of this session. What is wrist drop? Damage to which nerve leads to this condition? Describe the nerve involved under following headings. Okay, let's discuss. So wrist drop. Okay, the wrist has dropped means the wrist has flexed. Okay, why the wrist has assumed a flexion position? It could be because extension is not there. Why extension is not there? Because extensors would have been paralyzed. Nerve supply to extensor would be cut off. So loss of extension of wrist due to paralysis of wrist extensor is called wrist drop. Which nerve these leads to this? You know that for this you should know which nerve supplies the extensor compartment. Which nerve supplies the extensor compartment? The extensor compartment is supplied by radial nerve, and hence the nerve injured is radial nerve. Describe the nerve under the following heading. So radial nerve arises from posterior cord of brachial plexus. From where does the radial nerve arises? It is from posterior cord. Okay, root value. Okay, root value is C5, C6, C7, C8 even. This is what all people write. Okay, but as when I studied first year, I did this common mistake of not writing ventral primary rami of C5, C6, so on, spinal nerves. This you should write. Only then you will get full mark. You should not write it as C5, C6, C7, C8. No, this is not. You will not get marks. You should write it as ventral primary rami of C5, C6, C7, C8 even when spinal nerves. Whenever you write some questions, please put diagrams. You have to draw diagrams, only then you will get marks. Course and relations. So it arises from posterior cord of brachial plexus. It passes through axilla. It passes through lower triangular space. Okay, it passes through lower triangular space. After passing through lower triangular space, along with axillary nerve, along with radial nerve, you also have profunda brachii artery accompanying with it. And in axilla, it gives 3 supplies. Long head of triceps it gives, medial head of triceps it gives, and it gives posterior cutaneous nerve form. To these 3 it gives supply, and it passes through radial groove along with profunda brachii artery, and then it gives 3 structures. Lateral head of triceps, and it gives again medial head of triceps, and you will have anconeus. Okay, medial head of triceps, lateral head of triceps, and anconeus. Medial head of triceps is supplied in both axilla and in radial groove. In both you have innervation for medial head of triceps. Please do remember. And it also gives, here it gives the lower lateral cutaneous nerve of arm. So one cutaneous branch it gives. And in elbow, before see this is hand, axilla it has crossed. This is hand, axilla it has crossed, radial groove it has crossed, and it comes on lateral aspect of arm, and here it pierces the lateral intermuscular septum, and it comes on top of lateral epicondyle. Pierces lateral intermuscular septum, comes on top of epicondyle. Before coming, it gives 2 branches to 2 muscles, 2 main muscles, that is brachioradialis and extensor carpi radialis longus. Then it pierces the lateral intermuscular lateral intermuscular septum and comes on anterior aspect of lateral epicondyle. Then it gives 2 branches. The deep branch is posterior interosseous nerve. This posterior interosseous nerve passes between the supinator muscle and supplies all extensor compartment muscles. Supplies all muscles of extensor compartment. Here the superficial branch gives the sensory innervation. Okay, it gives sensory innervations to skin of lateral side of dorsum of hand and lateral 3 digits except nail beds. So if you want to make me to simplify it, we have to write all these chords, and then it passes through lower triangular space and it is accompanied by profunda brachii artery. This is axilla. Okay, in axilla it gives two main, you have to write about cutaneous branch also. Here for I am saying about the muscle innervation alone. Here it gives long head of triceps, long and medial head of triceps it gives. Okay, triceps. And it passes through radial groove, and in radial groove it gives 3 muscular branches. That is, again it supplies the medial head and it also supplies lateral head of triceps, and it gives anconeus also. Okay, and here so see, this is radial groove, this is axilla. So in radial groove it has come and it comes on lateral aspect, pierces the lateral intermuscular septum, comes on anterior aspect. So in elbow, here it gives 2 branches, that is brachioradialis and extensor carpi radialis longus. Then it divides into 2 branches, and one is the deep branch, that is posterior interosseous nerve is the deep branch that supplies the extensor compartment muscles, and another is that you have this superficial branch, it passes behind brachioradialis and then it gives the cutaneous innervation. This is what the whole thing. Okay, whole thing you have to write. Okay, please learn this diagram. And then what they have asked about the injury or lesions at the different levels. So lesion can take place at the level of axilla, it can take place at the level of radial groove or elbow or wrist. So you have 4 things. You have axilla, you have radial groove, elbow and wrist. Okay, if you see in axilla, it gives supply to see, if it is cut off here still, here in axilla itself, the whole supply will be cut off. Whole thing is cut off. If whole thing is cut off, nothing, everything will be lost. See, elbow extension cannot take place since triceps is gone, so that elbow is flexed. Yes, elbow is flexed. See, extensor are gone, wrist extensor are all lost. So wrist will be flexed, wrist will drop, so it is present. Sensory innervation, will it be present? It is also lost. So all things happens. Next, if you see for radial groove, see in axilla, whenever there is pressure is given to axilla, it will take place. It usually takes place in people who use a crutch. So it usually happens in crutch palsy. In radial groove, see, in radial groove, you already, here only it is cut off. See, here only it is cut off. But here in axilla itself, you have branch to long and medial head of triceps. To this branch is paired. Since this is paired, elbow will be able to extend. You will be able to extend the elbow. So weak extension would be present. But below that, everything is lost. So you cannot extend your wrist, so wrist drop will be present and sensory innervation is lost. That is what is given here. Elbow, see it at the level of lateral epicondyle, here it is lost. Here before itself there is a branch to brachioradialis and extensor carpi radialis longus. Here you also have a branch to brachialis. Okay, brachioradialis, extensor carpi radialis longus. Another branch that is given is brachialis. Please do remember, I forgot to mention that. Here, see, here triceps is not involved at all. It is paired. This fully is paired. So extension will be present. Okay, extension of elbow is present. And here if you see, this extensor carpi radialis longus is one of the extensor of wrist. So this one is paired. If it is paired, you will be able to extend the wrist. So wrist drop will not be present. You will have weak extension of wrist. Why? Because extensor carpi radialis longus is paired, and sensory innervation will be lost because below this level everything will be lost. And I said now posterior interosseous nerve is lost. So cut is here. So extension of elbow can be present and wrist can also be extended because extensor carpi radialis longus is paired. So sensory loss also do not take place because pin do not supply. This is not the supply for sensory innervation of hand. So sensory innervation is also present. It is not lost. So remember here. And at last you have this superficial at the level of wrist. At the level of wrist, you have only the superficial branch is getting, terminal branch of radial nerve is getting damaged. Only sensory innervation will be lost. All other features will be intact. It will be present. Like elbow is not felt. Elbow can be extended, wrist can be extended. Only sensory innervation is lost. Sensory innervation on lateral side of dorsum of hand and lateral three end of digits except nail beds. It's lost. Okay, next, new concepts, practice questions that can be asked. I would be happy if you are able to find out, you can find out. And if you want me to put a video on this, please do comment. And if you want me to change something, if I'm going fast, or you want me to include something, you can also tell me what are the topics that you want me to add. Here you have, this question is about the cephalic vein. They have given anatomical subnox. They have used a venous line to cannulate it. Mostly it will be cephalic vein. This is also essential questions that can be asked because brachial plexus is a 10-mark question. So that can be incorporated into case base. Whenever they say porter's tip hand or waiter's tip hand, it is Erb's palsy. If they say about fall on outstretched hands or arm pulled into dictionary, and if you see the sub questions, if it is about brachial plexus, then it is Clum case palsy. Thank you guys. I hope you share it to your friends and make anatomy interesting and easier for your exams. Thank you.